have him minimizing the motion just to make sure that his scapula is not going out of position. So what we're trying to do is strengthen the upper trap, which is not something that you see very often, but in throwers you have to do that. Well, the point of the scapular rehab is that you can help control pain, you decrease impingement, you facilitate the muscle education or re-education. In Ben Kibler's lab, they've shown that you can actually improve the strength of the rotator cuff by 23% if you can position the scapula. And you reestablish the force couples, which is key. Alignment, alignment, alignment. People understand when their golf instructor tells them that they can't stand like this, that they have to start out their swing by addressing the ball properly. I think that's key for the physical therapist to teach the patient. They have to take responsibility for their own posture. And when I see a 14-year-old or 15-year-old kid that comes into the office post-op and they've got those slumped shoulders, they clearly have not learned it yet, and they clearly can't have normal shoulder mechanics. And the way you sell that is enhanced performance, and I use the golf analogy frequently. Well, here's our problem. We evolved, but then we de-evolved. And actually, the name of this slide, the name of this photo is the evolution of the computer programmer. So that's what we're dealing with now, because so many of our patients just slump over desks. Some of us slump over the operating table and slump over exam tables. And our goal is to re-evolve the patient through postural training. So as Mark said, you've got to correct the soft tissue restrictions early: pec minor, major, subscap, latissimus dorsi, serratus anterior, if it's there. You will see patients whose scapulae really wing out when you have them in the supine position. You bring the arm overhead. Extremely common in rock climbers, in swimmers, and in throwers. And again, you want to correct the thoracic hypomobility, very, very common. You can use a foam roll for that. For $20, you can have the patient doing their own. So they can work on their alignment. They can use it for, in the top, they're using it basically for stretching and to mobilize the thoracic spine. And the bottom two, it's being used as a self-myofascial release on pec major and on the lats. As you're progressing the patient, you've got to remember that it doesn't go by the calendar. It's not they're supposed to be doing something at 3 weeks or at 6 weeks or at 12 weeks. Everybody learns at a different speed. There are people out there that the physical therapists know, they call them motomorons. It's very difficult for the patient to learn how to recruit muscles. And things change. I mean, try to get the attention of a 15-year-old kid. I mean, they just don't pay attention for very long. So if you have people with medical issues like diabetes, they're going to come along more slowly. Adaptive therapy is a term that Emil Dionysian, one of my friends from Kaiser in Orange County, uses to talk about how you have to modify the therapy to the patient. This slide is really for my partner Miguel Prieto, who tells his patients, God made rocks, God made flowers. And he puts his arm around his patient and said, you're a flower, and we're going to just have to go a little bit more slowly on you. So you don't go by the calendar. You want to make sure that the exercises they're doing are quality exercises, that there's good postural control, normal movement patterns are as normal as possible for that patient. And you want to do that. We don't have our patients doing 3 sets of 10. We want the patients to do it until they fatigue. And the sign of fatigue is they can't do it properly anymore and they start to substitute. So you've got to be really careful as a therapist when you're seeing 3 or 4 patients and trying at the same time and trying to monitor them all. So you want to focus on control rather than the number of reps, and teach patients to do things frequently rather than overloading the muscles. You want to go from submaximal and progress to maximal effort. You want to go from isometric, teaching them how to find the muscle, to eccentric, to concentric, and then go from closed to open chain exercises. Eccentric function, the contractions are more facilitatory than concentric. If you think about the muscles that act against gravity, those are the ones that are usually weak, the muscles in the back, as opposed to the muscles in front, the tonic muscles, which get tight. But eccentric contractions are more efficient, and they don't overload the muscle, and you get more out of it. Then we move to sensory motor training, progressive exercises, increasing proprioceptive input, working on stabilization of the joints, posture, balance, and gait. The goal for the therapist is to teach the patient to control their center of gravity. And then you progress the challenge as the quality of movement and stabilization improves. Cardiovascular, we want to get that involved as soon as possible because it increases the blood flow, so you improve the healing, and it improves the mental outlook of the patient. So the principles here are you want to correct the soft tissue restrictions early, restore muscle balance and length, proximal stability before distal mobility, quality is more important than quantity, and teach the patient to isolate the muscles and then integrate them and move them in a synchronous pattern. Remember that the physical therapist is the coach and the patient is the athlete. You teach them, they go home and do it. You don't have that many visits anymore unless you're in a different practice environment than I do. So you've got to make it the patient's responsibility. They've got to understand that. And practice is really important. So we'll conclude with this one, and hopefully the sound is on, Alan? Okay.
Det går koldt. Ja, ud.
Okay. Thanks.